Hello to everybody and welcome to this session of a recorded session for our tissue viability program, where we today are going to talk about wound assessment and what it entails to make a holistic assessment to get the best out of our management. So first things first, understanding what are the principles of wound management assessment. The first thing is looking at the etiology. What has caused the wound? We spoke about evidence-based practice, and if we remember what we talked about, it's important to understand what type of wound we have, to understand what type of guidelines we are going to implement according to that type of wound. Understanding what the factors that might delay healing, trying to eliminate them as much as possible, whenever possible. We will talk about how important it is to discuss with our patients and their carers to set a proper plan for therapy, what is acceptable to the patients, empowering them with knowledge, empowering them with all the options that are available, and once we implement the care to make sure that they do understand what that plan is, to help us to evaluate as we go along to see if we are reaching the goals and targets that we have set. I can give you an example of where in some countries we actually make, I think you might be knowing of the knowledge contracts that you have with your tutors. We can do the same type of contract with our patients, which is called a healing contract, to make sure that the patient understands what we plan to do, but also for the patient to understand what their responsibilities are in their treatment. Understanding that what we are doing here is a consultation. We are meeting the patient, we are understanding what is happening, what has happening, putting a plan of care. We can only do that consultation by understanding the problem which is at hand at the moment, what are the best evidence-based practices that we can implement by means of starting a proper and structured assessment. Only then can we implement the most appropriate treatment and understand the progress of the evaluation of our care. So wound assessment is very particular. Usually when we think about wound assessment, we look at the measurement, we look at the wound bed, etc. But what is very important is to understand that we need to have very good knowledge of both the anatomy and physiology and pathophysiologies. We need to understand how to determine what are factors that can interfere with the healing. We need to have the ability and the knowledge to get all the available data that we need, be able to analyze this data, and based only on that, can we able to identify what are the best options by removing all the hurdles in front of us and making sure that we can implement the best practices possible. So the aim of assessment, and we'll go through this many times today, but this is the essence of today's session, is understanding the causes, how we can correct the underlying treatments where possible, what are the appropriate treatments, and control what is happening in the wounds, but also understanding and setting the patient's expectations. And the wound assessment is quite big. It's not just assessment of the wound, it's assessment of the patient, assessment of the environment, assessment of the healability of the wound by means of assessing the patients themselves. Looking at what type of wound we have, the etiology of the wound, is it a venous leg ulcer, is it a surgical wound, etc., etc. That will give us the idea of what type of best practice guidelines we need to implement, making sure that we look at what the wound is telling us by means of looking at the wound bed, by looking at the edges, the peri-wound skin. Is there any infection? But also understanding the aspects that concern the patient, for example, things like pain And also remember that we need to understand, if we are not the first person managing this patient, what has happened before? What type of management was happening there? The management that was implemented, was it working or was it not? So in order to do a proper assessment, what we need to do, what type of wound is it? What is the history and the characteristics of the wound that we are seeing? Looking back at the history of the wound, the history of the patient, any comorbidities, etc., etc. What is the wound location? Is it in the lower limb? Is it a pressure ulcer? What is the size? How did it happen is very important also to understand. The length of time is it present? Has it been there for a long time, or are we the first people that we are seeing it? And going in depth to understand what was happening before will give us also a good idea of what might work and what might not work. So remember, when we are looking at a wound, never take it at face value. Determining the etiology is sometimes simple, but sometimes it isn't. We can look at a wound, maybe think it's a venous leg ulcer, but it can be an atypical wound. We'll see when we're doing the leg ulcer module that we can be looking at a wound that looks like a venous leg ulcer, but maybe it's a pyoderma gangrenosum. So this needs knowledge, this needs expertise, this sometimes also needs consultations. If we don't know exactly what we're looking at, if we are unsure of ourselves, we need to make sure that we get expertise of somebody else. We will see in later sessions as well that even sometimes when we are unclear, we maybe need to take a biopsy to see if there is malignancy in the wound, for example. So it entails a lot of knowledge, but it also entails a lot of interworking with the multidisciplinary team. So the first people we're talking about here in the multidisciplinary team would be etiological experts, for example, the vascular surgeons, the dermatologists, etc. So what are those factors that may delay healing? We need to do that comprehensive assessment, and we're going to mention this many times. Not just looking at the whole in the patient, but looking at the patient as a whole. Understanding that what we are looking at is part of an entity that has a lot of influence of what happens in the wound. The wound itself, what is the size, what is the duration, what type of tissue you have in that wound? Is it repeated? Is it recurrency? Is it chronic? The patients themselves, can they move? Do they have assistance? What are their lifestyle choices? Any medications? Any other comorbidities? The psychosocial aspect, the ability of the patients to come to follow-ups. Can they afford the treatment? What is their demeanor? Are they anxious, depressed? Are they in pain? How is that wound basically impacting their quality of life? And the underlying causes. If you have a pressure injury, you don't offload that wound will not heal or will take a long time to heal. So whenever we know the cause, well, we should find out what the cause is. Wherever possible, we should modify and eliminate as much as possible. Obviously, there are wounds which are not healable. For example, in irreversible ischemia, where we cannot treat the cause, but we'll talk about that in the next session, where we talk about understanding non-healable wounds and how to take care of these non-healable wounds. What happens if we don't plan? Not planning is planning for disaster. And this is what happens to our patients. We're going to watch a video at the end of the session today, and we will see that unfortunately many patients live weeks, months, even years with a wound because it has not had a proper assessment, a proper diagnosis. If we don't assess the wound, we don't know how to treat the wound, it will lead to complications, it will lead to deterioration, it will lead to inappropriate care. So even when we start off the initial consultation, we need to do documentation. And even when it comes to documentation, it needs to be evidence-based. It needs to be structured. What are we going to document there? So we need to have a proper structure. It needs to be governed by policy, and it needs to have a specific flow so that we are sure that we are documenting. This is one example of the Calgary-Cambridge guide. There are loads of them up there which you can use. One of the first very important thing, obviously, is creating that relationship, the therapeutic relationship that we have with our patients. We need to develop rapport. We need the patient and their carers and their relatives to understand that we have their best interest in care. We want them to heal as best as possible. We are there to support them rather than just to tell them what to do. Once we initiate that session, we start to identify the reason of the consultation, why we are there, understand the reason behind the wound, gathering all the information, so understanding the history of the wound, etc. Doing that proper physical examination. And when we're talking about the pathologies, there are different ways how to do physical examination. If we're talking about, for example, a diabetic foot, we need to check for neuropathy. We need to check for sensation. We need to check for all the neuropathies, not just one. But we'll go through all those details when we talk about the diabetic foot ulcers. What is the context of the background information do they have? What comorbidities are there? Then the most important thing that we usually don't spend too much time on, but we actually should, is putting it all into context. The explanation and planning, the discussion with the patients, giving them what is behind our plan of care, making sure that they do understand, giving them all the information and education, offering them also alternatives if they don't agree with what we are saying. But if they don't understand where we are coming from, it will be very difficult for them to follow what we are suggesting to them. And remember, concordance is important, but empowering the patients is also important. Making sure that they know and have education about their condition and how they can manage it. Closing the session, before we leave, we make sure that we have all the information provided, all the support that we can offer is provided. Make sure that the patients and their carers and their family are at ease with what we suggested, and we make the plan almost like a business plan, the long but also the short-term goals. Once we plan, we have a way forward. But before we plan, we need to start understanding by taking that history and making a proper examination. And that will give us the initial clinical impression. For example, it is a painful wound near the ankle of the patient. It's got irregular edges. It's exudating. So our first impression will be that it's a venous leg ulcer. That first clinical impression is not enough. We need to do investigations. We need to do consultations to make sure that what our clinical impression was is the actual diagnosis. Only then, and only then, once we have that proper diagnosis, can we implement appropriate treatment. Many times, because maybe we don't have enough time, we get into that trap of going in front of the patient, just opening the wound, looking at the wound, putting a dressing on it, and that's it. That is not wound care. That is application of a dressing, usually will not give us any good results at all. We have to do it in a structured way, in an evidence-based way, and the only way how to do that is by proper assessment. Proper assessment means proper plan of care, means proper healing of our patients. Once you get in contact with the patients, you know first impressions. You like somebody, you don't like somebody. We're not here to like or not like our patients, but what we need to do is, even just by looking at them, we have an idea of what the patients are, who the patients are, do they have good mobility, what is their BMI, are they overweight, are they not, what is their personal hygiene, what is their interaction with us. Giving that first minute impression is really, really important, showing them that we are there to create this therapeutic environment, this healing environment with them. And that healing and therapeutic care is not only coming from a dressing. Yes, the dressing is important, but having that rapport is so important. Making sure that we understand what are their concerns. Are they in pain? What is their cognitive function? Understanding where they are in their social status. So basically, if you try to think about it, wound assessment is so big that we can't do it in a few minutes. A few minutes will only give us basic information, maybe about what type of dressing we need to put on. Our goal is to get that holistic assessment to provide holistic care and holistic management. Again, here you see that you will need a lot of people in your multidisciplinary thing. Maybe you need a psychiatrist or psychologist. You need a social worker. Maybe you need even a financial advisor. So understanding all the needs from the very beginning will avoid you a lot of pitfalls along the way. The other important thing is documentation, because obviously documentation is a legal requisite, but it is also how we communicate with other people, keeping a proper history. And the documentation is going to reflect that process that we very well know. That assessment of the patient, the assessment of the wound, what our plan of care is, which is divided into those short and long-term goals, when we implement, what we need to be done, any consultation, and then once we put the plan and care in motion, we have to make sure that we conduct those evaluations, because it doesn't mean that we have a plan that will work for sure. Things can go worse, and we have to maybe rectify that course of treatment because something has gone not according to plan. When we are documenting, I'm not going to give you here a lesson about documentation. This is just to remind you what we've learned many years ago, for some of you maybe just a few years ago, that documentation is very important. It's not, as I said before, not just a legal requirement, but a very important part of communication, because many times the patient is not cared for by the same person. It is cared for by a different person, and having accurate and precise documentation is important for us to communicate with the other healthcare professionals. So this is a list. We are not going to go through all of them, of examples of what you need to record. What is suggested is that recording should be according to and governed by policies and protocols from your facility. Many times you will have, instead of a blank paper, you will have a list of things that you need to go through and make sure that you fill them up correctly. But remember, don't fall into the trap that we are documenting just for the sake of documentation. That documentation is going to build our plan of care. So everything you ask, all the answers that you put in, will reflect a need. For example, if we're documenting medications, the patient has a fungating ulcer, which bleeds quite easily, but they are on blood thinners. Do we need to do something about it? Do we need to refer and ask other clinicians? But there's a lot of things, obviously, that you need to document and you need to consult. For example, even test results. What are we going to do with them? Maybe for us, it's not important to look at the blood tests, but we need to refer to our colleagues, the physician, like if we see that there are results out of the norm. When it comes to documentation, as like anything else, evidence-based practice is the pinnacle of everything. This is one example. It's called the Bates-Jensen Wound Assessment Tool, referred to normally as BWAT. It is used quite a lot, and what you can see over here, it is very, very detailed and does not miss any elements. Unfortunately, sometimes I go and visit clinicians and ask them what type of wound assessment tool they use, and they tell me, we created our own tool, or we don't have a tool either. Recommendations suggest that you do use a proper wound assessment tool. This is one of my favorites because it is very comprehensive, doesn't miss any elements. In one of the reviews, it was suggested that it is one of the best tools that you can use. What I like about this one as well is that if you look at the bottom on your right hand side, it's got like a graph which is even at a glance will give you an idea of whether the wound is progressing, regressing, or stagnated. Also very important to understand is that this is not a time waster. I can give you the example of the Braden scale that used to take you quite a bit of time in the beginning, then it started taking you less time. That same review analyzed that it usually takes between 3 and 5 minutes to complete this tool once you get to know it very well. In the beginning, it can take you quite a bit more, even maybe, for example, I don't know, about 10 minutes, but the more you become accustomed, the easier it will become. But understanding the importance of it will help us understand that we need to take those few minutes to do all this communication, because this is the recording of everything that has been done, everything that is happening, understanding if our plan of care is actually working. And when you are documenting, please do remember, this is just as a reminder, please use the correct terminology. And even if you look at even accreditation processes, like for example the JCIA, they look at this. They look if there is a policy of terminology. Yes, I know there's a lot of policies, but these are all important. Making sure that everybody is referring to the same thing with the same terminology, using correct terminology. For example, if we're looking at the foot, the plantar and the dorsal aspects, looking at the anatomical direction, inferior, posterior. Anyways, this again needs to be governed by policy, and I'm also talking here to some of your leaders, and your leaders should make sure that we have these processes in place to facilitate you. Obviously, it takes a bit of education as well on how to educate people and train people on the proper terminologies, proper way of documenting what we are finding and what we are looking at. But referring back to that consultation that we're doing with the patient, remember that it's very important to create that therapeutic relationship. We talk about it a lot, and there's a lot of publications about that. But basically, a human talking to a human, empathizing with our patient, having those open discussions. And remember, we have 2 ears and 1 mouth. We need to listen more than we speak sometimes. We need to understand their perspective. When you share your ideas, your information, use normal language that they will understand. The ICE concept, ideas, concerns, and expectations. This is what we need to listen from our patients, because then we reach an agreement with them and we negotiate behavior change. For example, I like to use venous leg ulcers because they're usually some of the common wounds that we see. For example, your patient is removing the compression bandages quite often. We know that's dangerous. We need to understand why that is happening. We need to tell them why it is important to keep it on, and then go into a negotiation how to change their behaviors. This goes to smoking, alcoholism, bad habits, whatever it is. Make sure that when you reach the closure, the last thing before your goodbye, see you later, is to make sure that everything has been understood from your side, from the patient side to you, that we are all in agreement and that we are all happy with what we have decided that will be their plan of care for the future.
Before assessing a wound, review the patient's chart to determine the wound's location, size, and whether it's open or closed with sutures, staples, or steri-strips. Also recall the basic types of wound healing to determine which type is present. In wound healing by primary intention, tissue loss is minimal, the wound's edges are pulled together and closely approximated, and healing occurs by connective tissue deposition, as in a surgical wound. In wound healing by secondary intention, tissue loss is greater, the wound's edges are not approximated, and healing occurs by granulation tissue formation and wound edge contraction, as in a severe laceration or pressure ulcer. Wound healing by tertiary intention occurs when surgical wounds are not closed but left open for 3 to 5 days, allowing the edema or infection to diminish. The wound edges are then sutured or stapled closed. If the patient's initial surgical dressing is still in place, perform an indirect assessment. To do this, inspect the skin around the dressing for any swelling, redness, bruising, or other discoloration. After performing hand hygiene and applying clean gloves, palpate around the dressing to assess the skin temperature and detect any pain or swelling. Also check the outer surface of the dressing for moisture, drainage, and bleeding. If you detect a complication, such as frank bleeding, notify the physician at once. When removing a taped dressing, be sure to support the surrounding skin as the tape is being removed, and remove the tape in the direction toward the wound to avoid pulling on the wound edges. After removing the initial surgical dressing as ordered, perform a direct assessment. First, inspect the dressing, noting whether it's dry and clean or shows signs of bleeding or drainage. If a suture line exists, inspect that next. Normally, it may have clean, well-approximated edges, possibly with crusts, from wound drainage, inflamed, swollen outer edges for the first 2 to 3 days only, and bruised-looking skin around the suture line. Now assess for any odor and describe the wound color, which represents the balance between necrotic tissue and new scar tissue. Black wounds represent full-thickness tissue destruction, as in necrotic or desiccated tissue. Yellow wounds represent the death of subcutaneous fat tissue and muscle degeneration, as in necrotic slough and purulent drainage. Red wounds represent increased red or pink granulation tissue. Then palpate the wound edges. Note areas of localized tenderness or drainage. If you detect any drainage, note its color, consistency, and amount, which can be expressed as the percentage of the dressing saturated or the quantity of drainage, such as scant, moderate, or copious. If indicated, collect a specimen of the drainage, as shown in the video skill, collecting a specimen for wound culture. Measure the length and width of the patient's wound. Be sure to measure at the widest and longest points of the wound, using a disposable measuring tape. If the wound is oddly shaped, make a drawing or take a photograph of it. Rotate the swab along the wound's edges to determine if there are tunnels or deeper areas in the wound. Then, if appropriate, measure the wound's depth with a sterile applicator swab and convert that depth to centimeters. When you have completed your assessments, redress the wound.
Okay, just about done.
As part of your follow-up care, regularly document the patient's temperature and direct wound assessment findings.
Okay.
One of the mnemonics that we can use to give us a structure, remembering the structure, obviously apart from our policy, is a mnemonic that has been used for quite a few years now. It's Heidi. So looking at the history, what's the medical, surgical, pharmacological, social history of the patient. Examination head to toe of the patient. What are the investigations and consultations that we need to do? get that proper diagnosis, which will give us the pathway to care, which will tell us which type of guidelines we are going to look at, and obviously those guidelines need to be then reverted to the intervention or plan of care. Please never forget health-related quality of life issues on the patients. Look at the pain, look at how the wound is affecting the patients and how we can make them better, not just by healing the wound, but also by healing them as a person. When we're gathering the information, we can use all our senses. We listen to the patient, we listen to the history. Getting that history is very, very important, but listening to what they want to tell us, why they are there, why have they called us, what are their main concerns, but also their views. Look at the wound, obviously, understanding the condition of the wound, but look at the patients themselves, as we talked about before, their BMI, their demeanor, their build, whatever you can identify. For example, if you're looking at a diabetic patient, as soon as they start walking into your clinic, you start looking at their gait to understand, for example, if they have motor neuropathy. We use our touch. We'll touch the peri-wound skin, palpation, pulses, checking the temperature between limb and the other. Excuse me. And also understanding to make sure that we know also of the smells of the wound, but also sometimes the smells of the patient. Lack of hygiene of the patient, incontinence, can give us an idea that there's some underlying causes, but also the smell of the wound. Is it malodorous? Are there any particular smells? For example, understanding the smell of pseudomonas that we will call. So we have 5 senses, but obviously, please, the last sense we will not use at all because that is not correct. One very good example of a holistic assessment is the triangle of wound assessment, which has been around for a few years as well now, but still very, very relevant. Looking at the wound bed, understanding what is in the wound bed, looking at the wound edges, the parameter, the peri-wound skin, but also understanding what we are going to do there. So we look at the wound edge, we look at the peri-wound skin, and the wound bed itself, understanding what needs to be done. So there's a lot of publications out there. Making a decision in your facility to understand what works best for you. For some would be this one, for some would be the Bates-Johnson wound assessment tool. Most of you will have an amalgamation maybe of both, but please remember these are evidence-based tools. Please do not amend them. Properly give education to make sure that everybody knows what is expected of them when we are doing the wound assessment, notwithstanding what tool we are using. So, again, I know I'm being quite repetitive, but it's always very, very important to remember. It's important to look at the hole in the patient's leg, but it's very important to look at the whole patient. Once you start taking in all the assessment, then you start putting like the pieces of puzzle together. You get the whole picture. Identify what the wound is, identify what is needed, what can be changed, what can be addressed, what is the healing potential of the patient and the wound, making sure that we make assessment also for further damage of the wound itself now, but even for further damage and recurrence after the wound is healed. The basis of holistic assessment is not basic at all. We need to look at the social environment. We need to look at the psychological environment. We need to understand what are the abilities of the patients. What is hindering them? Where they are living? Do they have support? So we've spoken about this already. Understanding that we need to have people available for us in the multidisciplinary team, which sometimes we might not associate with wound management. Thinking about social workers, for example, Thinking about financial advisors, think about these patients, maybe not in your country, but in some countries where the dressings needs to be bought by the patients. Do they need financial support? Can they afford their treatment? So making that in-depth assessment, and please understand the importance of it, because whenever I give this presentation, one of the things that comes about is, but we don't have time to do this. But that is not planning, but planning for a disaster. Understanding that a proper assessment needs to be in place, it cannot be avoided, because if we avoid that, we end up with what I unfortunately sometimes see, what I call the dressing assembly line. It's almost like a factory assembly line. Patient in, dressing off, dressing on, see you later. This is not how we do a wound care. This is not even how we do dressing changes. Assessment is the basis of it all. It needs to be done, and we know the consequences of that, and we'll see that also how it can be disastrous for the patient in the last video that we see when we come to the end of today's session. Look at what can hinder the wound healing, the wound itself, the patient, and the psychosocial abilities of the patient. We are being quite repetitive, but being repetitive is very, very important, I think, today. We need to understand and we need to believe the importance of this. Because if we don't tackle all the issues, you might be putting on the best dressing, you might be using the best compression therapy of the world, but then there might be other things in the patient's environment that will stop the wound from healing. Looking at the peri-wound skin, there are certain things that we need to look at. So we went from the environment of the patient, the surrounding assessment, we're closing into the wound now. So before we go inside the wound, we look around the wound. Is there maceration? Is the skin exposed to further damage because of fluid or excoriation? I always advise you to use a barrier around the skin, around the wound, especially if you have a wound which is highly exudating. You can use something advanced like these lollipops or sprays, but if you don't have it at hand, even just a little bit of Vaseline around the wound can be of benefit. I know it's not sterile, but as we say in English, beggars sometimes can be choosers. You need to protect that peri-wound skin. One thing which is not very much well known is those rolled edges, sometimes called epipoli. These are usually because of infection. The epithelial cells cannot migrate and therefore need to be debrided. Calluses, we'll talk quite a bit when we're doing the diabetic foot sections. These calluses needs to be debrided. Here's another person for you in the multidisciplinary team, because this is usually done by the podiatry. If you don't remove that callus, the wound edges cannot come together, but also that callus is creating its own pressure. Induration, erythema, but also crepitus is a sign of infection which is now migrating into the tissues surrounding the wound, indicative of spreading infection. So again, these things need to be documented very well. Another thing which is obviously important is the wound measurement. Is the wound getting bigger? Is the wound getting smaller? Or is it the same every time we see it? The recommendations are that we don't do these type, especially the contact type or two-dimensional, three-dimensional type of measurements every time we change the dressing. Usually it is suggested to do it, for example, once weekly, because if we do it too often, there might be more chances for error. What is very important is the way you are doing it is the way your colleague is doing it. Again, should be governed by policy. So two-dimensional means by using these disposable paper tapes, which are not costly at all, but you can also take the circumference of the wound, as you see on that tracing at the bottom of your right hand side, if you want to check the depth, then you can use a cotton tip applicator, as we saw in the video previously. Again, the importance of everybody doing the same thing. Are we using the patient's head as 12 o'clock, patient's feet at 6 o'clock and going in that direction? Or are we using the direction of the greatest width and the greatest breadth, or whatever you call it? Because as you see, even from the examples of those pictures taken from a publication from Wounds UK, different sites of measurements gives you different results. What I used to do, and this is a tip I would suggest to you, is that you can use a skin marker. Just make dots of where you are connecting the sites to take the measurement. So when the other nurse comes, she can see the 4 dots and use those same measurements for you. The use of those type of tracing paper is, I think, better than using a ruler, because length times breadth is for a square or a rectangle. Most of our wounds are irregularly shaped, so wound tracing is more effective there, and you just plot and see the area of the wound quite easily. These tracing papers are 2-layer. The first layer that touches the wound obviously should be sterile. You mark the top part with some type of marker. The bottom part can be removed and thrown away, and the top part can also be placed on the documentation of the patient. One of the things that we are using a lot today, obviously, is the use of digital photography. So digital photography can be just taking a picture, but can also be as part of a software where you have software on your phone or in your camera or whatever it is. You take the picture, and that photogrammetry will suggest what the size of the wound is, sometimes even the type of tissue of the wound, volume of the wound. There are other technologies, for example, laser technology. Again, if you're using this type, usually it's taken every time we change the wound. The important thing is how we take the picture. Rules about taking the picture is that when we're taking the picture, ideally we should be using the same technology every time, because you know that using one phone with using another phone will give us different resolution, different probable colors of the wound. Make sure that you are using the wound as a focus. So as you see in the picture in the center, first of all, there's a lot of clutter in the background, which should be avoided. I see a lot of picture with swabs, with buckets, whatever is around. Focus on the wound. You see the difference between the picture in the center and the picture on the top right corner, where the wound is focused. Especially if you're using application, you need to focus. Try as much as possible always to take it at the right angle, using the right amount of lighting, so that one picture is representative of the next picture as well, because we have the same situation. So again, this should be governed by policy, but even just common sense here tells you what needs to be done. When we're talking about wound management, we can encounter also tunneling and undermining. So undermining is that tissue destruction underlying the intact skin around the wound margins. So if you go beneath it, for example, with a cotton tip applicator, which should be sterile, we can understand the depth, and we can analyze what the real size of the wound is. So for example, in that picture you can see another wound which we might think is a satellite wound, but it is actually the same wound. Tunneling in wound care is a dead end, because obviously if we have a connection, it's a fistula, which is something totally different. Again, happens mostly because of infection, and it can go down to the surrounding tissue such as muscle. What is very important is that, again, we document these in a methodological way. It's a fistula, which is something totally different. Again, happens mostly because of infection, and it can go down to the surrounding tissue such as muscle. What is very important is that, again, we document these in a methodological way. So if we look at the way of doing it, we calculate again that the patient's head is 12 o'clock and the patient's toes are 6 o'clock. So if we have undermining as is shown there, we can document it that there's undermining between 4 and 6 o'clock, and there is tunneling at 7 o'clock. So we are documenting exactly where it is around the wound, no matter what shape the wound is. It doesn't need to be round. Just make sure that you look at the patient's head as 12 o'clock and then do the clock face accordingly. Now doing it in a structural way, this is based also on another tool which goes towards the wound healing continuum, and it involves three things: the wound bed, infection, and exudate. When we look at the wound bed, we need to look obviously at what type of tissue do we have. Do we have granulation? Do we have epithelialization? Is there debris inside like slough or necrotic tissue? Is there hypergranulation, which is indicative of infection? So looking at the colors of the wound is very important because it tells us what type of pathologies we have present. It tells us to show what state of healing we are at. Is the wound getting better? Is it getting worse? Or it is stagnated? Which tells us if what we are doing is successful or not. The first color we are referring to is black. Black refers to necrotic tissue, and we are here more so identifying eschar. So that eschar is black or dark brown in color, which means that the cells are dead. Unfortunately, you cannot do a mini CPR on a cell. A cell is dead, is dead. What we know is that there are different types of eschar, which can be dry and moist. We'll see in the next one, but usually this eschar can harbor bacterial growth and also will not allow epithelialization to go. That eschar will inhibit the progression of your wound. However, when we have, for example, a reversible ischemia, is it advisable to remove or not? Going in for debridement is not as clear-cut as we think. We need to look at what those types of wounds are. We have here, for example, two cases where we have in the center a dry eschar on a patient's heel. Is it hindering the patient? Is it creating problems in the wound? Will we be better off if we leave it be and not remove it? Making a decision is not as simple and clear as we think it is just by looking at a picture. A picture can tell 100 words, but in wound care, I don't believe that very much. You need to look at holistically. Can we give, for example, this patient an offloading device and they can still walk? Do they actually walk? If we remove that eschar, what are we achieving? We're going to expose bone there. If you look on the other side, that wet eschar that usually harbors infection, usually there's pus underneath it, and our first idea is obviously, yes, take the patient to the operating theater and remove it all. What is the condition of the patient? What are we going to achieve? So your first question should be, what will be achieved if we debride? Cleaner wound? Yes, but what else? So you need to go in depth, and again you need to consult with for example, vascular surgeons if it is advisable or not. Because not all black is black. You have three different types of blacks here. You have that necrotic tissue, which is because of pressure damage there. We have a hematoma, which obviously if we will remove, we can get more bleeding. Looking at that Pandora's box of picture 3, what is the circulation there? There is obviously a lot of edema there because there is a lot of maceration. Is there enough circulation there for an amputation? If we're going to amputate, are we just going to amputate? So on, so forth, so on, so forth. Maybe for this patient it's better to let the toes mummify and they will fall off by themselves. But again, you cannot judge by just a picture. You need to have a proper assessment done. Observation of the wound bed continues with the colors, looking at the yellow wound, which denotes to slough. And please remember that slough doesn't mean infection, but it can predispose to wound infection. Slough is usually looked at in a way that it is a big problem because it's got all these bad things in it, which can predispose to the wound not healing properly. But remember, there's a difference between acute wound slough and chronic wound slough. In an acute wound slough, the white blood cells die off. They turn into that very light shimmer of yellow on the top, which usually is cleared away by means of natural autolysis, by means of the macrophages and other proteolytic enzymes which are in the wound bed. So usually this is done normally. If you have a balanced moist wound environment, the wound will clear it off itself. You don't need to debride. But chronic wound slough is another problem because it can predispose to the production of biofilm, excess matrix metalloproteinases, excess bacteria, excess burden on the wound. So we need to remove that bioburden, because if we don't, it will prolong the inflammatory process. So therefore, when it comes to chronic wound slough, our objective most often than not, almost every time, is to remove it as effectively and efficiently as possible. But again, are you sure that you know what we're looking at? If you look, for example, at the picture in the center, that's a tendon. If we think that's slough and we try to remove it, we're going to be in big trouble. The one on the bottom, fungating breast cancer, if we try to remove that slough, for example, with a blade, what we're going to have? Pain, bleeding. So again, it's not simple, it's not clear-cut. We will also discuss, when we're talking about next time, about the wound bed preparation, the different types of debridement and desloughing, because nowadays we're even actually differentiating between desloughing and debridement, and we'll talk about that obviously next time more in depth. What we know is that eschar and slough in the wound bed in a chronic wound is detrimental. It contains all the problems that we talked about previously, so whenever possible, whenever advisable, we need to debride and or deslough the wound as best as we can, as efficiently as we can. The next color is the red wound. The red wound is in the granulation stage, where granulation should have what we call the beef red granulation, cobblestone effect. There's a lot of circulation in that wound. Remember that these wounds will definitely need protection using of proper non-adherent dressings that will not damage the wound, will not cause not just the wound problems but also cause the patient pain. Balanced moist wound environment, but we'll look into that next time. Remember that if the tissue in the wound is pale, very regular, there is exudate and the edges are not healing, so at the top you see that rolled edges that we talked about previously. This bleeds very, very easily. If you pass a piece of gauze on top of it, you'll see but little bleeding. This wound is highly infected. You need to treat the infection here. The pink wound is the epithelialization. You have the epithelium migrating from the edges. Again, this type of wound we need to protect with a non-adherent dressing, balanced environment. Usually if you press very gently the sides of the wound, you see the epithelial tissue wrinkling. This shows you healthy epithelial tissue. But unfortunately, sometimes we have life that throws us a curveball. We have these types of wounds which have all the colors in it. What are we going to do? What we need to do is make sure that we are still moving the wound towards healing. If you look at the example of this wound, probably the first thing to do would be to remove the necrotic tissue, the slough tissue. We see evidence of spreading erythema, which means spreading infection. So treat each color as needed, giving priority to what needs to be given priority. So there's no template to go on these type of wounds. You have to assess each wound on its own self. There is no one size fits all, but the terminology and ideology behind it is usually follows the same type of patterns. Infection we will talk about next time during the wound bed preparation, but remember that we need to assess if the wound is infected or not, and according to that assessment we need to implement care according to. But as I said, we'll go into more depth next time. The storyteller of the wound, which is the exudate. Quick question to ask here, just think about it. Do you think exudate is good or bad? Can be both. We need to look at the color, the volume, the viscosity, and if there's any odor there. So in the exudate continuum here that we see, it's quite easy to document because we look at this score according to the viscosity and the volume. So any that falls into the green zone is advantageous. It gives us a moist wound healing environment. If we're looking at the amber zone, if it has come from the red, it's obviously getting better. If it has moved from green to amber, obviously there is room for concern. Anything which is in the red, it needs to be investigated immediately. And we need to understand that exudate is very beneficial as long as it has got the correct color, has got the correct viscosity and volume, and no odor. Because that exudate provides that natural autolysis, that moist environment that will allow fibroblast proliferation, etc., etc. So keeping that wound moist is really, really important. But sometimes we have a wound which is too dry or too wet. So those low exuding wounds, it could be because of systematic problems like dehydration and hypovolemic shock, but in lower limb wounds, usually this is because of lack of circulation, which could be usually referred to the microangiopathy. High levels of exudate mean that there might be comorbidities, like for example problems with the cardiac, renal or hepatic. Could be because of the pathology of the wound. For example, we know that venous leg ulcers will give us quite a lot of exudate, especially if there's lymphedema present, but also understanding that it could be a sign and symptom of an infection coming in, because we know infected wounds will start giving you more exudate, and not just the amount of the exudate, color, etc. When we are managing exudate, what is important is not just to treat the symptom, but to treat the cause. Usually the sum that we need to do the equation is exudate equals foam dressing. In that case, I look at the foam dressings as a bucket underneath a faucet that is leaking. Yes, you need it in the beginning to contain the fluid that is coming out, but understanding what the cause of the exudate is the key. If you have biofilm, you manage the biofilm, you treat the biofilm, you will see that within a few days that exudate level starts going down and down and down and down. So yes, in the beginning it's important to use those foam dressings to wick it up. Always important to protect the peri-wound skin, but treat the cause, not just the symptom. And these are some examples here for you about the factor type, for example, the stages of wound healing where you have a lot of exudate and not that much exudate. Local factors of the wound that we talked about previously, so ischemia will give you less exudate, but edema, infection, fistula will give you a lot of exudate. systematic factors like drugs, malnutrition, age, etc., etc. So, and here you have a huge list. The good thing is that you have a recording. You can go back to it. We don't need to go through all of these, but you need to educate yourselves to try to start to understand what is causing that low or high exudate, and not just use a foam to wake up the excessive exudate and maybe use a hydrogel in a dry wound, but understanding what is causing it and always treat the cause, not just the symptom. What we also understand is that those high levels of exudate will give us problems. There's a lot of proteases. We talked about MMPs last time. It interferes with all the cell proliferation, and if we do not manage these problems, your wound will not heal. Your health-related quality of life, your life of patients will go worse as well. Because it gives us a lot of psychological effects, that fear of leaking, soiling, smell. They become socially embarrassed, they become depressed. But not just that, the risk of infection, frequent dressing changes, pain, etc., etc. So please make sure that you start educating yourselves even just by looking at the color of the exudate that we mentioned previously on the exudate continuum. Understanding the colors of the wound will help you understand what is going on there. Most of us are very accustomed to that green exudate, which is pseudomonas, but this is not just pseudomonas. So educate yourself, learn more. Obviously, these sessions are here to start you thinking of what you need to explore more, what you need to understand better, to go and do further reading and further education of yourself to be able to manage the wounds a lot better. Again, here some of the examples of color and consistency, not just of the exudate, sometimes even of the slough, because these are all telltale signs of what is happening there and what we need to do. One of the conundrums that we always have is, how am I going to document exudate? Am I going to weigh the dressing? Am I going to try to pick it up with a syringe and calculate it? Quite impossible. So many publications have gone through trying to explain this, and one agreed methodology of doing it is the description of the exudate levels from dry to leaking. So you look at the wound. If there's no visible moisture, it's dry. It means that it can be a problem here because your wound is dry, and we know that we need a moist wound healing environment, so that moist environment is important for healing. Wet means that your primary dressing is extensively marked, so we have exudate marking your dressing, which means that they can have peri-wound maceration, but also means that there is something going wrong in the wound. It could be just maybe lymphedema, which we cannot control immediately, but understanding why. Saturation means that you might have the primary dressing wet and you can have a little leaking, but leaking means that then we are having the dressing totally saturated, going through both the primary and the secondary dressing. Again, this should be governed by policy and guidelines from your facility, but try to choose an easy way like this, which will help you document a lot better. Odor is usually forgotten, and again here you have an example of how to document odor, because you know that the presence of malodor, it's getting wetter or worse, is one of the signs that your wound is getting better or worse. So again, looking at the type of documentation that you need. The fifth vital sign, pain, and this is where we need to have other people helping us, and these people that I'm talking about here are the wound pain team. Well, not just the wound pain team, but usually you have the pain consultants in your hospitals and facilities, which will guide you on what type of analgesia you need to use. It is many times dependent on the type of wound you have, so type of pain is very indicative, and also understanding the triggers of the pain and how that pain is described by your patients. Make sure that if you need to give analgesia, give it before you do the dressing, not afterwards, to try to keep the patients in the least pain possible. So understanding this is really, really important, because assessment is also important, that it is looking at every aspect. So how do we document pain is also important. One of the ways how to do it, not just in wound care, it's done in many different types of cares, but it is a very well accepted way, which is called WILDA. So what does the pain feel like? Give us an explanation of how you think the pain is. What is the intensity of the pain? And here is where we use the VAS score, the visual analog score, or the score from 0 to 10, best and worst. So this is part of the assessment, which I'm sure that you are already using, but it is only one of them. The next one is the location of the pain. Is it just on the wound? Is it radiating somewhere else? Has it now been moving or extending? Don't you feel any pain, which could be part of neuropathy? What is the duration? When does it start? Is it all the time? Maybe showing us that we are not using the correct dressing. Maybe showing us that if it is intensifying, maybe there is infection and the wound is getting worse. What makes it better? What makes it worse? Always choose atraumatic dressings. Make sure that the dressings you are using are not adherent, that when you apply them during the wear of the dressing and removal is causing the patient the least pain possible. So the pain management in patients with wounds needs to be governed, as we said, by means of consulting the pain management team. If you don't have a pain management team, sometimes you will find anesthetists that are quite well versed here in this type of care, but ideally you would have a pain team that will come and look at the therapy that needs to be provided. If you're interested, you can look at the WHO ladder of analgesia. It refers mostly to cancer, but can also be applied to pain in your patient's wound. So that's another piece of further reading for you. When we're looking at the assessment, referring back to what we talked about in the beginning, don't look at the hole in the patient's leg, look at the patient as a whole. What are the lifestyle and functional status of the patient? Does the patient have support by family or other people? Can they help themselves? Does the patient work? Is it causing them not to go to work? Will they be able to work with the type of wound management that we are going to give them? How will it affect their economic status? Can they perform their normal practices in their life? Do they require assistance? If they require assistance, how can we help? Maybe we should call in the social worker to see what type of assistance we can provide for these patients. Any health habits, bad habits, maybe because they are used to it, or maybe because they can't afford not to. For example, bad eating habits, eating junk food, because junk food is less expensive than healthy food. But do they have, for example, alcoholism, smoking, etc., etc.? Do they have any sensory impairment? For example, in diabetic patients, loss of protective sensation, but in many patients, because of disease or older age, maybe they don't see very well. They can't function properly on their own. Also looking at the environment, where do the patients live? I can give you an example of a patient we had quite a few years ago, where we had this patient who had a bilateral amputation because of irreversible ischemia. He was still, even after a bilateral amputation, quite a happy chappy. We discharged him, we saw him about a month later, and he was one of the most miserable people that I've seen. It was our fault. We didn't do a proper environmental assessment because we discharged this patient to a third floor apartment without an elevator. So he was basically thrown in there as if he's been thrown in prison. He couldn't get out. Nobody was going to see him apart from once a week. His brother used to go and drop some food for this patient. He couldn't even look outside because the windows were quite high. So if they're being discharged, where are they being discharged to? If they're on a wheelchair, do they have access? Looking at, for example, a bathroom. Is it safe for these patients? Do they need handles? Do they need bars? So again, your social workers will be very helpful here. This can not only affect wound healing, this can affect them physically, but also affect them mentally. We know that people have committed suicide because of wounds and how they affect their life. So it's very, very important through your assessment that we make these patients' lives as better as possible. One very interesting publication, and there was actually more than one publication that came out from the UK, but also from other countries, was referring, obviously this is very British, the tea and toast syndrome. So what is this? This is, again, not just for wound care, but is very applicable to us as well. So these are people who live on their own, advanced age. Maybe they don't have access to going out to buy their wares. I'm sure you're thinking that, oh yes, but nowadays we can go on Deliveroo or Uber or whatever, or Grab or whatever it is and order. Try to imagine a 92-year-old woman who has visual impairment and you give her a smartphone. They don't have people to bring them in food. They end up getting just tea and toast. For example, it can be whatever you think about, which would be the easiest. And they end up that their nutrition goes down the drain. And this is a reality. This is something which we are seeing all over the world, wherever region it is, because of the advanced age of our patients. The more we go, the older our patients become, and the ratio of older people has gone through the roof. So your environmental assessment, getting in those social worker, making sure that our patients are being discharged to a safe environment. If you are dealing with community nursing, even when you go and do your visits to the patients, you can do the assessment yourself and then refer if you see any problems there. One acronym that has been used quite a bit is milk and cows as well. So milk means managing the wound, making sure that we look at how the wound is affecting our patients, what are the investigations that will lead us to the right direction of what type of standard of care, looking at all the factors that can impede wound healing, and case for kill infection, make sure that we have proper infection management of our wounds. We need to consult with others. Have we missed anything, or have we misdiagnosed a wound? Observe the patient's behavior. How are they keeping themselves? Do they have any mental impairments, for example, dementia? Do they have any problems with their gait? Are they very heavy? Weigh all your factors. Why is the wound not healing, or why is the wound not progressing as quickly as I want them? But then, obviously, the last one is the most important for me. Systematic approach. No wound is an island. Look at the whole patient, not just at the hole in the patient. And I've talked to you previously about a video that came out from the National Health Service in the UK. It's a video I like using a lot. Hats off to the NHS for doing this. It will show us the life of a fictitious character, which is called Betty. But although she's fictitious, you can realize once you start seeing the video that we have seen a lot of Bettys around. And this is a story of a lot of our patients.
It's about Betty, a widow who lives by herself in a village 10 miles from town. Betty has a good social life, enjoying her walking club, despite a bad knee, and a weekly aquafit class followed by a meal out with friends. At her 70-year health check, Betty was overweight, but the nurse put it down to her age, so there was no mention of changing Betty's lifestyle or health advice. 4 years later, one day while out walking, Betty grazed her ankle. She put a plaster on it and then spoke to her local pharmacist, who suggested a dressing to try. 6 weeks of self-treatment weren't helping, so Betty's GP prescribed antibiotics, not realising that they wouldn't help Betty's wound. 2 weeks later, Betty's practice nurse dressed the wound. For the next 6 weeks, Betty struggled to the surgery every week to get the dressing changed, but there was no improvement. Over the next 6 months, the general practice nurse tried lots of different dressings, but the wound got worse. The dermatology clinic confirmed it was an ulcer, but the test results didn't get to Betty's GP practice. Although the nurse was doing her best, her training was out of date, so she didn't feel confident applying the type of dressing needed. The appointment slots were too short, and treatment was delayed as equipment wasn't working. Meanwhile, Betty couldn't bathe with the dressings, so didn't feel clean. She worried about the wound smelling, so didn't want friends to call round. She couldn't go out with her walking club, nor go to aquafit. Because of her wound, she couldn't have the knee operation that would have helped her get more mobile and lose weight. So Betty felt isolated and depressed. She was in pain and housebound with a variety of district nurses visiting, all trying to help but making slow progress due to lots of different reasons. To cut a long story short, it took 2 years for the wound to heal. From a simple graze to her leg, there were countless dressings, many people involved, a stay in hospital to deal with a nasty case of cellulitis. Only then did Betty's wound finally get the correct treatment and the pain subside. But how could things have been different?
So basically, if I ask you if you have ever met Betty, I am sure that you tell me that I haven't met Betty, but I have met a lot of patients that have the same problem. Lack of knowledge, lack of focus into wound care, not putting our patients through a proper assessment will lead to disaster. Betty had a wound for 2 years. I can give you another example of a female again from the UK. She was 16 years old. She had these horrible ulcers on the shin of her legs. Exudative, extremely painful. Started when she was 16. 5 years later. So basically the life that she should have been enjoying as a teenager was ruined by these wounds. Only after 5 years she was referred to a proper educated tissue viability specialist, did the proper consultations, did the proper treatment. The wounds were healed in 3 months. We are playing with patients' lives here, guys. Let's make sure that we do a proper assessment. Where we don't know, we say we don't know, refer them on. So by means of doing things right, let's see how Betty's life was changed.
Wind the clock and take a look. We are back at Betty's 70-year health check, where she was heavier than she should have been. The healthcare assistant made a care and support plan for Betty to keep her healthy. Betty lost some weight but was worried about her tired and heavy legs. The general practice nurse assessed Betty and prescribed compression stockings to reduce the risk of leg ulcers and arranged regular reviews. 4 years later, one day while out walking, Betty grazed her ankle. She put a plaster on it so it wouldn't stick to the compression stockings she wore every day. She then asked the advice of her local pharmacist, who knew just what to do. The local NHS had agreed a protocol for anyone who had a lower leg wound, so she advised Betty to see the practice nurse at her GP surgery without delay. The practice nurse dressed Betty's wound, prescribed some cream to moisturise Betty's skin and some medicine for the pain. She referred Betty to the leg ulcer clinic for a full assessment, and a couple of days later the clinic confirmed it was a venous leg ulcer. Treatment of the wound started straight away with specialist compression bandaging that had been proven to work. The nurse also gave her an information leaflet all about it. The nurse prescribed a wound cover so Betty could have a shower and encouraged her to keep as active as possible. This made such a difference. Betty returned to the clinic the next day and again a week later to have the ulcer checked and measured. Betty was pleased to see it getting smaller. Progress. After 2 weeks in bandages, the nurse gave Betty a prescription for compression stockings to wear then and in the future, and advised Betty to keep her leg moisturised. 8 weeks from visiting the practice nurse, the ulcer had completely healed. 6 months later, Betty was able to have her knee operation that meant she could rejoin her rambling club and get back to her old self. Let's recap on how things were different. For Betty, early, best practice treatment stopped the ulcer in its tracks, and within a month the wound had healed. Betty's active social life that kept her healthy and in good spirits continued, and her knee operation would go ahead without delay. And for the NHS? Providing care in this way cost around 10 times less than the first scenario. It's a win-win for everyone. Let's make it happen everywhere. Through the clock and take